Good evening, everyone. So today we are going to have the second session in the rapid revision of pediatrics by Dr. Prithiviraj sir. I welcome you, sir, again for this wonderful session taken by you. And in the first part, it was really helpful for everyone. And today we are going to go for the neonatology part 2 and nephrology. Thank you, sir. And I request you to take over the session, sir.
Acha. Thank you, Raghunandan. Good evening to one and all present here. So today we are going to further complete our remaining topics that is in your neonatology, and then we will start nephrology. We cannot complete nephrology today. We will see few topics which are very essential for both theory as well as practical, and rest we will complete in the next week. So the topic which I have chosen for your neonatology, these are the questions which have been asked in your various university exam in various state, and they are very common and very important question both in Viva and practical. So always see what is there is a question always coming in your in theory paper as a 2 mark or 3 paper. What is IUGR and what is SGA? Most of the time, what we do this we use this synonymously. We think that IUGR and SGA are both or same, but statistically as well as clinically they are not same. There are few difference with which you have to tell that this is because of the IUGR or SGA. See, small for gestational age, which is known as SGA, it is some kind of statistical definition. The SGA is nothing but it's a statistical definition. So whenever you use a growth chart, for example, if it's a preterm baby, you use a chart called as Fenton chart, which is applicable from the 20 weeks of life, 22, sorry, it's 22 weeks of life to 50 weeks of 22 weeks of gestation to 50 weeks of gestation. And we here plot it and we see whether it is below 10 centile. If it is below 10 centile for that population, norm as per the age, sex, okay, then we describe that as an SGA. Normally, SGA can be seen in even a preterm baby, in a term baby, and it's normally not most notly associated with any pathology. But when you go for an IUGR, this is also seen in both term, whereas also in preterm, we don't have any statistical there is no statistical definition for IUGR. IUGR, what is IUGR? They will ask you what is the acronym mean of IUGR? Because right now it has been R initially it was said as retardation. Now the terminology has been changed. It is said to be in utero growth restriction, not retardation. It's kind of malnutrition kind of thing. It's kind of malnutrition in utero, which in turn caused the baby to not attain its to not do, attain its genetic potential. As a result, the child is not only small for age, also have some kind of pathology. If they ask you to identify a baby who is of IUGR, always see they will be very their weight will be mostly less than 10 centile. In some baby, it will be even less than 3 centile. That is one of the typical feature you will see. Most of the baby will be less than the 3 centile. They have more skin folds, mainly more than 3 fold in gluteal region in your back, more than 3 skin fold, and also they will have like old man faces because they have no subcutaneous fat, so you will have a old man faces, peeling of skin. So they will be looking like a malnutrition. You see when a quassioker or marasmus, it's like a marasmus. When you see a marasmus child, similar marasmus child in a newborn, we term it as a IUGR. So this is the uh, uh, difference, peculiar difference, which is associated between your SGA and IUGR. In most of our day-to-day practice in neonatology, we use it simultaneously, synonymously, but there are few difference which your examiner may ask in the exam. So when you go for IUGR, it is about symmetric and asymmetric. Symmetric IUGR is the IUGR where your cell number of cells has been affected. So all of the body will get affected. It's not brain sparing. So the head circumference, the length, the uh, abdominal circumference, everything is going to affected, and those babies who are get affected are always less than 32 weeks. So whenever any insult that occurs before the week of gestation 32 weeks, then these babies overall cell number will be decreased. As a result, the entire body get affected. There will be no head sparing. So all circumference, head circumference, arm circumference, the length of the baby will decrease. The most common cause is genetic disorder and torch infection. These are the important causes, right? And now, when you go for asymmetrical IUGR, normally this babies more than they have passed the 32 weeks of gestation. It's a late onset, and most common IUGR is your asymmetric, not symmetric. Symmetric IUGR is not common. Your asymmetric IUGR is most common. Since it occurs after 32 weeks, the cell number is not going to be affected, whereas the maturity of the cell is going to affect, and you will have a brain sparing effect. So the brain of the baby get spared from the effect of the IUGR. So the head circumference will be near normal. So normal head circumference, whereas the length and abdominal circumference and the weight, they all will be decreased. So most of the common is chronic hypoxia, like the mother is having PIH, if the mother is having kind of infection, valid in utero hypoxia, if the mother is having uncontrolled diabetic DM, which all lead to placental insufficiency. Placental insufficiency. And also, if a mother is malnourished, if she's not taking the adequate amount as per prescribed RDA, recommended daily allowance for a pregnant woman, then also the baby will not get adequate food, nutrition, and the child will develop asymmetrical IUCR. So about what is the ponderal index? They will ask what is ponderal index. Okay. This is also an important question, tumor question, and also Viva voc. So it is nothing but length, sorry, weight in kg by length in centimeter cube. In symmetrical IUGR, whenever you see all the part of the body is going to affect it. So your brain is also not spared. As a result, the weight and length is equally affected. As a result, the ponderal index will be near normal. It's equal to 2. Whereas in asymmetric IUGR, your head circumference is going to increase. As I said, brain sparing, the length is also decreasing. So length is decreased a lot compared to the weight. As a result, the ponderous index weight will also be decreased much along. As a result, the ponderous index will be less than 2. So this is the difference between your symmetrical and asymmetrical IUGR. Okay. So now important thing is low birth weight. So based on the low birth weight, what is low birth weight? How you will define low birth weight? So initially in the definition class, when we started in neonatology, we already discussed about the low birth weight. Any weight, irrespective of the gestational age, less than 2.5 kg or less than 2,500 grams. If examiner asks in what unit you will describe the weight of the baby, whether it will kilogram or in a gram. As you know, the electronic weighing machine, which is as per the IAP, AAP society guideline, it should weight, the accuracy should be more or plus or minus 10 grams. So they are prescribing it in a gram. So whenever an examiner asks about the birth weight, always try to tell it is in 2,500 gram, 3,000 gram. So this is the correct way of telling birth weight of the or weight of the baby, not in kg, for any newborn below the age of 28 days. Unless the child crosses the age of 28 days, then you can use kg. Before that, always try to tell the weight in the kilogram, sorry, in gram. So why I was a preterm and IUGR. So there are few specific complications that are associated with the preterm baby and IUGR. Mind you, IUGR can occur in both preterm and term baby. Okay, preterm and term baby, whereas preterm is something below 37 weeks. And they may be SGA and also IUGR, but IUGR cannot be a SGA because, as I said, the SGA as a statistical definition, they are no pathology, but IUGR is always something related to pathology. So preterm baby or any babies who have not completed 36 completed week of gestation. So what are the peculiar uh, problems you will see in a preterm baby? Hypothermia, they have perinatal asphyxia, respiratory condition or like HMD, which we will discuss, bacterial sepsis, apnea of prematurity, metabolic, more common hypoglycemia and hypocalcemia, hematologic anemia. Please note it. Preterm babies versus IUGR, right? One common one both are most commonly most likely both the babies preterm baby as well as IUGR babies are more or less they have similar complication or problems, whereas there are few complications which are specific for preterm, whereas IUGR they will not have that. In preterm it is more common they go suffer from a condition called as anemia of prematurity. Okay. This is one thing, whereas IUGR, because they suffer from a condition in utero, hypoxia, which is chronic in nature, as a result, these children will release erythropoietin in response to hypoxia. Because of the erythropoietin, their RBC mass increases. As a result, they are more prone for exactly excellent polycythemia. And since there is a polycythemia, they will have higher viscosity. So they are more prone for stroke-like condition or any thrombosis-like condition, which is more common in IUGR. And also, there will be more excessive RBC turnover and breakdown. So they are all more prone for NNJ. See, NNJ is common in preterm, also in IUGR, but IUGR the risk is more because of the following pathophysiology. So this is one of different. Preterm only suffer from anemia, whereas IUGR they will more suffer from polycythemia. Two, feeding problem and poor weight gain is more common in preterm and tummy. Whereas babies with IUGR will have the same complication except few conditions like meconium aspiration is more common in IUGR. Hypothermia, hypoglycemia, I said, polycythemia, I said, one thing they never, IUGR baby will never suffer from hypocalcemia. These two main difference. One thing is IUGR will have a polycythemia and they never suffer from hypocalcemia, not hypoglycemia. Hypoglycemia they will suffer, but not the hypocalcemia. This is the few two major difference you will see between the preterm as well as the babies with IUGR. So what are the other thing which you will be seeing? Yeah, resistation. It's very difficult for any preterm between 34 weeks or less than 32 weeks or any weight less than 1.5 kg or any baby with IUGR. See, these babies are more prone for, as I say, perinatal asphyxia. So perinatal asphyxia, so they require neonatal resuscitation. So you, as we discussed in the previous class, in a detail, in a vast detail about the neonatal resuscitation, these babies are more likely go till the till the chest compression, nor epinephrine. So they need an extensive neonatal resuscitation. So a team must be ready for doing the same. At the same thing, they are more prone for hypothermia because same thing, same whatever risk factor I said about hypothermia, they have large body surface area compared to their body weight. They have large head size. They don't have no brown fat, no subcutaneous tissue, and no the skin are very fragile. As a result, they are more prone for hypothermia. And in previous class itself, I told how to take care about the temperature regulation for a preterm baby. What are the things you should do? Always receive this baby in a pre-warm towel. The radiant warmer should be on 30 minutes before the anticipated delivery, receive in a pre-warm towel. Never drive that baby. Never dry the baby. You should always receive in a plastic bag, which is made specially for this kind of preterm, less than 32 weeks or less than 1.5 kg or IUGR babies. And the radiant warmer may have a pre-warmed mattress, and you should transport this baby. This is very most important. Transporting this iris baby in neonatal incubator to the NICU or SNCU, whatever. And they are more prone for infection. As I said, uh, they have an immature skin, they have immature immunity, so they are more for infection. And also in the labor room, SNCU and NICU, they are exposed to environment which make them very prone for infection because of the immature both cellular and humoral immunity. And they are more for hypoglycemia and hypocalcemia. So so how to prevent this temperature? So another one of the important component which the government of India is right now recommending, and in the year of 2022 November, the preterm World Preterm Day week or preterm babies week was celebrated between November 14 to 21, and in date of November 17, 2022, our Niti Aayog, along with WHO, UNICEF, came with a guidelines for low birth weight and preterm care, in which they have specifically highlighted the importance of the kangaroo mother. So, what is kangaroo mother care? Kangaroo mother care is a technique where we provide support to the low birth stable. This is very important. Stable low birth weight and preterm babies by giving STS and prevent hypothermia and related complications. So, kangaroo mother care is nothing but a support which we give to all the stable low birth weight and preterm babies by providing skin to skin contact with the caretaker or caregiver and prevent hypothermia and its related complication. Right. So this is the important thing. So what are the three components? So position, which we will discuss. In kangaroo protocol, they can do exclusive breastfeeding or express breastfeeding, express the breast milk and give. And when you do this both the thing properly, the child could be discharged as early as possible, and also prevent the morbidity and mortality. There were very retrospective studies, all many RCTs and meta-analysis confirm the use of the effectiveness of KMC. And right now, the KMC is been recommended in all healthcare facilities, starting from primary health center where delivery start till your tertiary care center, like your AIMS, JIPMER, or state medical colleges. KMC has become a standard of recommendation for the low birth weight and preterm babies care. As a result, it prevents the morbidity and mortality associated with these babies. So, who are the eligible baby? As I said, all stable, low birth weight, preterm baby. more likely 1200 to 1800 gram, more than 28 weeks babies, or sometimes we say 32 weeks babies. So 28 weeks to 32 weeks babies, they are initially they will be hemodynamically unstable. For that, we have to take care. Once they become stable, you can directly give to the mother, or else if they are stable from birth itself, you can try. But most of the time, they are hemodynamically unstable. So the weight is also 1200 grams and more than 32 weeks. In our setting, we give more than 1800 grams or 1500 grams also on more than 32 weeks babies if they are stable directly to the mother or any caretaker. Who are the caretaker you can give? So if mother is unwell or the mother is not wanted right now, she is suffering from something. So who are the caretaker who can give? They could be anyone, even the father, mother-in-law, father-in-law, mother's fathers, who are ready to take care of the baby without any fear, can give the kangaroo mother care. And the mother, if they are stable and they are confident, they have to become confident only if you counsel them properly, then only they will come for the kangaroo mother care. So these are the eligibility. So eligibility criteria, if the baby weight is less than 1200 grams, listen to it carefully. If it is less than 1200 grams, it will take few days, few weeks for them to get stabilized and to be provided with KMC. If the weight is between 1200 to 1800 grams, it will take few days to get stabilized hemodynamically, and then the baby could be given to the mother for KMC. If the weight is more than 1800 grams, and if the weight the week of gestation is more than 32 weeks, most of the time they are stable at birth itself. You can start KMC at delivery room. So this is the recent guideline that was given by the WHO UNICEF in the year of 2022 during the World Preterm Week, where the KMC can start as soon as birth if there is no contraindication. They have given many terminology which is not it's very cumbersome for you to remember in a vast syllabus like for research. But you should know what is the recent take over the KMC and what is the components. This is very important. Three components: position, feeding, discharge. Because this question was asked in the year of in your INICET May 2021. Mind you, in INICET May 2021, they asked which of the following is not the three component of KMC. This was the question which was asked in your INICET May 2021. So this topic is very eye yielding for both your entrance exam as well as for your university. Now, what about the initiation? So initiation of KMC, I should say you have to counsel, proper counseling of the mother, also the parents, also the other people who will be with, along with the mother in the home, so that home-based KMC can also be provided. This home-based KMC was also a new terminology, came in the year of 2022, that home-based KMC, all the stable babies who have been discharged, the mother may continue to give this home-based KMC, which helps them to gain weight, prevent infection, increase the bond. Also, it increased the exclusive breastfeeding rate. As a result, home-made KMC is right now advocated. So this counseling session is not only for mother, it's also for the father, it's also for the family members who will be along with the mother in the home. So they will also know how to provide KMC and what are the uh, steps to be followed properly, so that they will be confident enough to support the mother in the home for providing a proper KMC. Providing a proper KMC itself reduces the morbidity and mortality, and it has been proven in many studies. It has also been reviewed in many RCTs meta-analysis. Okay, so mother's clothing, any clothing which is comfortable to the mother, with a strap, with the front of the body should be exposed, where the baby should be will be kept and should be covered with any dry, clean cloth. So, what is a kangaroo position? This is important. When you see the baby, Okay, sorry. So procedure of KMC kangaroo position. This is important. See that the baby should be between the mother's breast. Right now you see it should be mother's breast. The head should be kept turned to one side. So what does this mean? So this is the thing because to prevent suffocation, which may happen unknowingly sometimes when mother sleep in this position and keeping the head directly towards the mother's chest, sometimes she may suffocate the child. As a result, the child go may get respiratory distress. Sometimes he may get asphyxiated. So to prevent this dreadful thing, we always keep the end of the child to turn toward the one position, like such that the eye contact can be maintained between the mother and child. Why this eye contact is important? As I said, the reflex. So everyone read about this maternal reflex for the breastfeeding. You know the oxytocin and the prolactin. Prolactin is the thing which produces the milk, whereas the oxytocin will help to a process called as galactokinesis. So it has to eject the milk. It is a let down reflex or ejection reflex. In order to activate that ejection reflex, the mother should have a love bonding with the baby. This may be improved by eye to eye contact. As a result, the bonding improves, the love of the between the love for the baby increases, which increases the oxytocin release, and there will be ejection of milk. And now this ejection of milk will be used for breastfeeding the baby. So feeding is you can provide breastfeeding in KMC position. So you can provide in KMC position breastfeeding, or else you can even express the milk and give. Express the milk and give via paladi or katori feed. Yeah. So what are the monitoring you will this positioning, and then you have to support the bottom as in the picture. Sometimes we use a strap like this, which will support the bottom. It is a frog-leg position. So the bottom of the baby should be in a frog-leg position. So baby must be between the mother chest. It too should be turned towards the one side. Baby's bottom should be supported, which could be supported by the mother itself with her hand, or else a strap can be used for supporting, and the baby's leg and hip should be in the frog leg position. This is the typical kangaroo positioning, which is an important question, and in Viva they can ask. And what are the things you should monitor? You should monitor the pulse, you should monitor the respiratory rate, you should monitoring the color of the baby, and any discomfort is there with the baby. Any discomfort with the KMC position. So this should be monitored in the baby. So yes, you have to support the privacy. If mothers seek privacy, please provide that privacy. These are the things which should be taken care during providing a kangaroo mother. So when to stop KMC? As long as the baby wants it. Whenever a baby don't like it and is trying to move away from the mother's breast, at the time you should stop giving this kangaroo mother's care, right? That is wriggles out and weigh more than 22.5 kg or 2,500 grams or gestation of more than 12 months. So these are the criteria where when you have to stop giving KMC. So another important question: what are the limitation of low birth weight? Uh, not low birth. Sorry. What is the feeding? How to feed low birth weight neonates, which is an important 10 mark, 5 mark should be known. Okay. So what are the limitations? So this is the thing which helps you to know well. As it say, the breastfeeding skills, which I will be discussing, already discussed. So if you want to know what are the breastfeeding skills, please see to the previous lecture. So breastfeeding skills which are routine, which is normally present, which is not present at the age of less than 28 weeks and develops at 20 to 32 weeks. And most of the time, more than 32 weeks, they have this sucking reflex. It also most likely develop after the sucking breast birth for developing the sucking reflex develop at the age of 32 weeks and swallowing. This also start to develop coordination start from 34 to 38 weeks. So that is timeline difference. So any babies who are born during below 32 weeks, they don't have this routine, sucking, swallowing. As a result, they are not going to feed on the breast. So you are not in no way they're going to get direct breastfeeding is possible. So for these babies, what type of feeding you will suggest? So we will see it in the next few slides. Another thing, sickness of the baby. If the child is very sick, the child is somewhat lethargic, altered sensorium, she's very drowsy, he or she, then you cannot feed the baby. Most of the time, as I say, they lost IVWL. What is I with IWL? Insensible water loss, right? Insensible water loss. They are more prone for because their skin not very transparent, the skin are fragile and transparent, right? As a result, they lost more of extracellular fluid. Mind you, the extracellular fluid or water balance of the neonate of premature newborns is around 90%, whereas the adult is around 60 to 70%. So the baby has to lose this 30%. So how this 30% is going to be lost? From your skin, from the evaporation. As a result, there will be more insensible water loss that cannot be taken care by your breastfeeding alone. Breastfeeding alone cannot take care of this eye fluid requirement. So we have to give alternative way. So most of the time we give the IV fluid. Supplementation as less than 32 weeks. You know all your vitamins and minerals. No, so less likely we don't go for vitamins, but minerals. Less. This mineral accretion. What is accretion? It is stored in your body. What is accretion? Define accretion. Accretion is nothing but storing of mineral in the body. Minerals in the body for the physiological function. In the body for physiological function. Right. So for this to happen, it most of the time the accretion happens during the accretion of minerals. It is known as fetal accretion of minerals. It happens in utero, most likely between during the third trimester. Sadly, for all babies who are born less than 32 weeks, more specifically less than 28 weeks, they surpass this stage, so there is no accretion. So they are deficient. They are highly deficient of this mineral. They are highly deficient of these minerals. Now, when these minerals are not been given for the appropriate age and sex limit, the child will develop the deficiency, which will impact the physiological function of the child, various physiological function of the baby, leading to complication. In order to prevent this, you have to do supplementation. This supplementation is not going to be provided by the breast milk. And last thing is gut maturity. Most of the children's gut is immature, less than 28 weeks more specifically. So as a result, they cannot directly breastfeed. So the appropriate method is determined by the sickness of the child and the feeding ability, which we'll see. Okay. So choosing initial method. So I will be going towards as soon as possible because it's a revision. So see to the chart. This is given in the OP guide in your book. Just wrap it up. It's very easy, not that tough. If the child is more than 38 weeks, I said 34 weeks, because in 34 weeks, they have developed all the routing. Routing reflex is most of the time mature. Sucking also is mature. And swallowing coordination swallowing, breathing coordination. They both have moderate maturity. So, so you can try breastfeeding for the babies who have crossed the age of 34 weeks of gestation. Start initial breastfeeding. Observe if the positioning attachment are good. If the child can effectively suck long enough, at least the child should suck for 15 minutes. If she or he is sucking for 15 minutes, positioning and attachment is good, then continue breastfeeding. No, the position attachment is okay, but she's not sucking. She take rest in between. She can just suck for 3 minutes and take rest for 4 minutes. Again doing. So that means our sucking, she has good snooting, she has good sucking reflex, but the swallowing, breathing coordination has not yet matured enough. That has not been, it's not, it's not matured enough for a continuous sucking. So this, or if the baby is between 30 to 34 weeks, as I said, at this time the swallowing, breathing coordination starts to mature. Or if more than 34, but she has to take sex because for few children, for few babies, it takes time. Even for it takes sometimes 37 weeks to get a good maturity of the swallowing breathing condition. In that scenario, or if the child age is between 30 to 34 weeks, starts feed by food or palad. Observe whether the child is accepting well without any spilling or coughing and able to accept adequate amount. If yes, go continue with it. If no, she's not. She's coughing all the feed. She's spilling it out. And she's not expecting what we are expected to give 20 ml, but she's not even drinking 10 ml. Then, no, the child still requires some time for the maturity of his or her breastfeeding reflex. Then go for orogastric or nasogastric tube. So you have to insert the orogastric or nasogastric tube. Then you see whether the vomiting abdominal stage is present or not. If yes, no, continue gastric tube feeding. But no, the child is vomiting or abdominal distension. As I say, this is not only about the reflexes, it's all also about the gut maturity. If the gut is immature, sometimes most of the time it's a leaky gut. So whatever you give, what it does, it leaks into the submucosa where it comes contact with the capillaries and come with the your immune system is already immature. That immune system will have a response like inflammatory response. This leaky gut will increase the inflammatory response and will lead to this abdominal distension and also some kind of vomiting. So in that case, or if the child is less than 28 weeks, you start time. This is the way you have to choose initial feed method. Now the child you have started on some one particular feeding method, and now you want to what you have to do? You have to escalate to the highest method so that at end the child should directly breastfeed from the breast. So how to do that? So if initially the child is on IV fluid and you see the bacha's hemodynamics has become stable, start tropic feed. What is tropic feed? What is tropic feed? Tropic feed is otherwise known as MEN. What is MEN? It is known as minimal enteral nutrition, right? It's known as minimal enteral nutrition, where you give a minimum amount of food, please, sorry, mother's breast milk, minimum. We give around 12 to 24 ml per kg per day. Normally, this kind of babies will be less than 1.5 kg only. So, as a whole, they will receive around 20 to 40 ml only per day. This is the only total quantity they will receive. But what it does, it helps in the gut maturity because it acts as a tropic. What is tropic? Tropic, tropic or nothing but which helps the gut villus to grow and attain its maturity, which helps by this tropic factor, which is tropic feed, that is known as MED. So this you can give by orogastric and monitor for feed intolerance. If the child is expecting it well, then increase the feed volume and slowly you tap and stop IV. And now you stop IV fluid, the child is on orogastric too. You gave it for 2 to 3 days, and the baby's age also increased to 30 to 32 weeks. Now, 2 to 3 days, there is no there is no abdominal distension, there is no vomiting. The child is uh, taking she or he is taking the feed well. Then you start with spoon feed. Now, spoon feed or katori feed, you can start once or twice daily, along with the orogastric feed. You are giving every 3 hourly, so totally 24 hours. So 8 times a day you are giving orogastric feed. Now, what you are doing, you give 2 times spoon feed of the same amount which you giving orogastric, and the orogastric feed you give 6 times. As the child expecting it well, so you tap on the orogastric feed and increase the spoon feed. At the same time, start non-nutritive sucking. What is non-nutritive sucking? And anyone can answer it? Non-nutritive sucking. Here, in order to help in the maturity of breastfeeding reflex in the baby, after mother expresses her milk out from the breast, the baby is given to suck on her empty breast. Empty breast. So in this way, it trains the baby. It trains the baby for effective sucking. So this is known as, we are not giving breastfeed, but we are training the baby for acquiring the best breastfeeding reflex so that he or she can breastfeed within few days of time. Once he or she improves, or if he or she gains weight once our maturity has been improved. After he or she has started on infant on spoon or palade feed, then you start to give on breastfeeding before each feed. Before every feed of spoon or palade, give to the mother. Try whether the child is able to suck the breast properly, whether the attachment is good, whether the positioning is good, and there is an effective suckling. And if the child is effectively breastfeeding, then tap her and stop the spoon feed. And and also once the mother is confident, will stop the spoon feed and directly to give the baby to the breastfeed. So in this way, you have to progress the feeding pattern in the preterm low birth weight. So what are the nutrition supplementation? For any baby between 1500 to 2400, 499 gram, go with vitamin D and iron. So vitamin D recommendation even for preterm or for any term baby of this 400 international unit OD till age of 1 year. Iron should be start after 6 weeks with a dose of 2 to 3 mg per kg per day OD for till the age of 2 years. For any baby less than 1500 gram, same vitamin D and iron. But the vitamin D prescribed for any babies less than 1500 gram would be, anyway, it should be 400 international unit to 700 international unit per kg per day in OD basis till 1 year of age. And vitamin D, normally we start within 40 days of life for which, iron. This is also 2 weeks, okay? Your vitamin D is also 2 weeks. Once the child is somewhat same. So human fortification, as I say, they require supplementation of minerals, of many micro nutritions, for which you have to do human milk fortification. If this is not available, go for preterm formula. You can give multivitamin, calcium. So already I discussed about it. So what are the growth monitoring? Now, how to growth monitor the low birth weight? See, normally the term babies they have 80% of water, and as I say, for a normal adult it is 70%. So the child has to lose 10%. It takes 7 to 10 days to lose it, and the baby will gain again, return to the birth weight. For a preterm baby, it's as I said 90%. So for 70%, at least 15 to 20% of water should be lost. But for them, it takes 14 to 21 days to do so. And again, they will retain the birth weight by the 21 days. That is 2 weeks for term baby, 3 weeks for the preterm baby. After that, from the particular age where they have returned to the birth weight, they will start to improve the weight by 15 to 20 gram per kg per day till they attain the weight of 2.5 kg. Then after that, the weight increases 20 to 40 gram per day. So this is a growth chart, which is I'm saying this is went on. You see, from 22 week of gestation to 50. This is for till the character gestational age comes to the 40 weeks, and then you can switch over to the WHO chart. Till then, you should use federal chart for the growth monitoring for preterm babies. After they attain the character gestational age of nearly 40 weeks, then WHO chart can be used. So, what are the causes of insufficient weight gain? You are seeing a baby who is coming to you. The mother is very reluctant. She is saying that the baby's weight is at the birth was 2 kg. Now, she born at 32 weeks, and now the age postnatal age is 1 month. But the character gestational age is 36 weeks. Now, so you have to plot it in the till 40 character gestation age. You have to plot in front and chart. And mother is saying that weight is right now 2.1 kg. So in past 1 month, she has only attained 100 grams. And you know, for 32 weeks, you said it is 14 days. I am adding. Okay, it's not that much weight. Okay, 14 days. Okay, 14 to 20. So for 14 days, I'm taking. So she attained 2 kg. After that, I say for every day, it should be 20 gram per kg. So for our weight was 2 kg. So 20 to 400 grams. So 400 grams should be attained in every day. So the 15 days, 6,000 grams. Sorry, my dear. No, it's 40 grams. Sorry, 40 grams. So 60 grams, 600 grams. She would have attained. So actually, our weight should be around 2.5 or 2.6 grams. But the mother is saying our weight is 2.1 1 kg. Why? So, what are the causes of the inadequate failure? It is mainly because of inadequate intake, which is the most common cause. This is the most common cause. Then it's an increased demand. Inadequate feed, if you're breastfeeding infant and formula feed infant differ. For sorry, in spoon or paladite feed as well as the breastfeed infant, it differs. In breastfeeding infant, the one thing is incorrect positioning and latching. If the latching and positioning is not correct, whatever the mother gives 8 times, 10 times a day, it is not going to be of no use. If unless a proper latching and positioning is maintained, the child will not have an adequate breast milk. If there is no adequate breast milk, the child will not gain weight. This is the most common mistake a mother does. Mother does. As a result, the child will never gain a weight. If any mother comes to your clinic or to the OPD and she's saying our breast milk is insufficient, the mother baby is not gaining weight. Always recheck our positioning as well as the latching method. If everything is correct, then only you have to evaluate. In 90% of cases, this is the problem. Because of that, the bacha or the baby doesn't gain adequate weight gain. And second most common thing which mothers do, they do not give a night feed. Minimum 3 to 4 night feed should be given because that increases the prolactin secretion. Night feed increases the prolactin secretion. In last video, I have described about the prolactin reflex and when it increases, when it decreases. Please see to that video. So because of the increased prolactin, only more breast milk will be produced. More breast milk will be produced, then only the bacha or baby will get adequate breast milk. If the child is on a Palade feed or preterm formula feed, if the mother uses an inadequate technique, incorrect technique to mix that the appropriate amount of formula into the warm water, or she bottle feed the child. If any of the scenario happens, then the child will not gain the weight. Over diluted formula feeding and breast bottle feed will never improve the increase the weight gain. So you have to troubleshoot that particular aspect. If these are the symptoms, these are the most common is inadequate intake, as I said. And another least common, and also you should take care of is increased demand, most commonly cold stress. If the bacha or baby is not properly covered in the home. So as I said, in hypothermia, your basal metabolic rate increases. If basal metabolic rate increases, all the energy the child acquires is used to maintain the temperature. So the energy is not used for the weight gaining of the child. As a result, the child will not gain weight. So cold stress hypothermia must be avoided in all preterm low birth weight baby until they gain an adequate weight of 2.5 kg should take care of. And if the baby is on corticosteroid, like in BBD, we give corticosteroid. So because of that, the child may not gain inadequate weight gain. So other problems like jaundice, they are more common. Polycythemia, acid escalate, anemia, I also explained. Preterm, these are very important. Retinopathy of premature itself is a topic which you are already read in your optal in optal. So in want of time, I'm not going to discuss much. Respiratory distress, I'm going to discuss in the upcoming slide. So coming over the respiratory distress. So when you will say the child is having respiratory distress, see to the picture given in the slide. Whenever a child has a respiratory rate of more than 60, so as per your IMNCI, do you remember the IMNCI guideline for the pneumonia? In that, it has given any respiratory rate of more than 60 per minute in a infant less than 2 months tells you the child is having tachypnea. Not only the tachypnea, see, there are few conditions called as effectless tachypnea. What is effectless tachypnea? Can anyone tell you? Can anyone tell it? What is effectless tachypnea? The child will have increased respiratory rate, but no increase in work of breathing. How do you tell there is no increase in work of breathing? What are the things which you have to see in the baby or in neonate or in any infant to say there is a work of breathing? Any retraction, subcostal, intercostal, suprasternal. Most of the time, suprasternal go for in favor of any upper airway obstruction or nasal flaring and use of accessory muscle like sternocleidomastoid. Accessory muscle. If this are present, then you say the work of breathing is increased. But here I said there is no work of breathing. So what are the condition you will think of effortless tachypnea? Very good. It is mostly if an effortless tachypnea always rule the metabolic cause. It could be because of acidosis, which is maybe because of hypoglycemia and the uremia. Sometimes your congenital heart disease can just present with tachypnea. There will be no dyspnea unless there is a severe critical congenital heart disease. So these are the two conditions where the child may present with as effortless tachypnea. But here, for respiratory distress of respiratory origin, there must be an increased work of breathing. So what are the work of breathing? You will see there is a nasal flaring, there is a grunting, there is an apnea or dyspnea, there is a small recession along with cyanosis. Very good. So any of this thing is good present, then you go for then you say the child is suffering from respiratory distress. So what are the two scores we use for the child infant to assess the respiratory distress? One thing which is given in your OP guide, 10th edition or also in 9th edition. So you should know that it is your Downey Vidyasagar score. Vidyasagar is another scientist who also helped in the scoring. But in book we give a Downey score only. So Downey score you should must remember maybe a 2 mark question. So what are the parameter you see? Respiratory rate, cyanosis, retraction, grunting, and entry. And you score 0 to 2. Any score more than 7 means the child is having an impending respiratory failure, and you have to intubate and mechanically ventilate the child. If the score is between the 4 to 6, the child is having moderate respiratory distress, then you have to give a CPAP. If it's 0 to 3, it's a mild. You may wait and watch in room air. Saturation is maintaining. Most of the time it improves, or else you can give a supplemental oxygen in the form of nasal cannula at 1 to 2 liters. It could be a low flow or high flow, depending upon the condition for which you are giving. And you have to assess. You have to assess this Dowdy score every 1 to 2 hours to know what is the grading, because it's a dynamic score. As a respiratory distress, sometimes it will resolve or it may progress to go to an higher level score, and where we have to escalate the respiratory support. The above picture which I have given, it's for the preterm babies less than 35 weeks, which we 35 weeks, most likely more less than 32 weeks we use. It is a Silverman Anderson score, which is also given in the book. It has been written in, but the picture and the criteria has not been given. It is a Silverman Anderson. So respiratory versus non-respiratory. Non-respiratory, respiratory, you have TTN, respiratory distress, meconium aspiration, pneumothorax, PPHN, pulmonary hypoplasia, TEF, and diaphragmatic cardia. Infection, yes, reflectless tachypnea. It's also because of sepsis, meningitis, and pneumonia may cause effect. You are aware tachypnea with distress. What are the other causes like congenital heart disease, as I say, hypoglycemia? Yes, polycythemia anemia can present. Coronal atresia, hydrocephalus, intracranial hemorrhage, yes, and respiratory rate suppression from maternal narcotic use, like if mother is on opioids, or if the the mother was given GA, it may go for neonatal depression and then inborn error of metabolism. Right. Okay. So just clinchers. I am not going to discuss this topic because it's a revision class and we don't have much time, because as a result, I am just going to the glimpses, read it. These are the glimpses, at least you should know, so that you can make up a story in the paper. But this is itself a key points I am discussing for every topic of from upcoming slides. So I will not be discussing much on it. Just the key points which you should write in the exam. Any term baby boy born via elective C-section develops respiratory distress within 6 hours of birth, and you are seeing an X-ray of an a normo or hyperinflated lung, or hyper volume, large volume lung with an sorry with a fissure and bronchoalveolar marking. So bronchoalveolar marking, you are seeing the prominence of fissure on the hyperinflated lung, and most importantly, what is sign is called, right? What is this sign called? The because of perihilar lymphatic prominence of lymphatic drainage of the TTN. What is the pathophysiology of TTN? Simple, because these children are born by elective C-section. There are no way to take out this fluid which is normally present in the lung. Fluid in the alveoli is not removed, and for some time being, it takes time for that to be removed physiologically. Till that, these children will have some form of respiratory distress, and this fluid will be removed via your lymphatics. When this lymphatic converges toward a perialar region because of more fluid going, you will see this kind of streak pattern, perialar streak, which is a perialar lymphatic. We go give a Peri-ilar streak pattern, which is known as sunburst sign. Sunburst sign. So, what is the treatment? Give CPAP, wait and watch. If distress is more, you can give CPAP. And after, as the child settles down, you can de-escalate and give a supplemental oxygen and then you are proceed to the room. So TTN is not, it's a diagnosis of exclusion and it's a not that much serious thing. But what is respiratory distress syndrome? This is very uh, important because this is one of the important question. So it happens more than less than 34 weeks in 20 to 30% of babies. Or in less than 28 weeks, it has been seen that it is seen in 80% of babies. So, apart from preterm, what are the other risk factors like acidosis, hypoxia, maternal diabetes, which is we tell it as a term RDS, and C-section can even increase the chance of RDS. What is the pathophysiology? It takes first 6 hours of life, the child should start develop. So, what happened in prematurity? There is the surfactant deficiency. There is structurally immature lung which go for atelectasis. Because of atelectasis, there will be a VQ mismatch and also hyperventilation. This in turn causes hypoxia because there is no oxygen and carbon dioxide cannot be washed out because there is an atelectasis, that will be hypercarbia. So, hypoxemia lead to metabolic acidosis and hypercarbia lead to respiratory acidosis, which this metabolic acidosis is one of the risk factor for causing persistent of your pulmonary vascular resistance. As a result, persistence of your pulmonary vascular resistance, like your increase in the pulmonary vasoconstriction, will have an impairment of your endothelial epithelial integrity. As a result, all the fluids start to extravasate, fluid extravasate within the alveoli, alveoli, leading to form of proteinaceous exudate, this leading to the condition of RDS. So this is the pathophysiology. Writing this is enough, more than enough for your pathophysiology. Then you go for management symptoms. So this is RDS. You see, they will have a low volume lung. You see, this is a very low volume. You cannot see anything here, right? And they have reticular granular pattern. And you sometimes you see this you can see, right? Reticulogranular pattern represent the is because of your collapsed alveoli. And this air bronchogram. See, you are seeing something like this, no? This is collapsed alveoli. Because collapse there is no going to air, so all air will be seen in the bronchioles or bronchi. So you will see air here because this is collapse. So bronch is filled with air. This is known as air bronchogram. So low volume lung, reticulogranular pattern because of collapsed lung, and air bronchogram because alveoli is collapsed. So air has no way to go into the alveoli. As a result, it stays in the bronchioles and bronchi, which in X-ray will be seen as the air bronchogram. These are the typical RDS X-ray, which is seen. So what is the management? Go for TABC, temperature, airway, breathing circulation, CPAP. CPAP is the recent respiratory, sorry, it's the standard recommendation in any preterm low birth weight babies of more than 34 weeks, more than 0.11500 gram, with spontaneous breathing effort, but have respiratory distress. Then you will have to start CPAP. What is CPAP? Which I will see in the first coming slide. Exogenous effect, if the baby, if given for CPAP, you give a positive respiratory end pressure, which prevent the alveoli to collapse. So once the alveoli is not collapsed, or now the air will enter the alveoli, there will be a diffusion of gases, O2 into the capillary, CO2 from the capillary into the alveoli. So there will be a ventilation, oxygenation, and it will end the hypoxemia There'll be no pulmonary vasoconstriction, so more blood will be flowing, and hypoxemia has been taken care of. So no acidosis. Every organ will get the oxygen. As a result, the hypoxemia and hypercarbia clinical features will settle down. It most of the time CPAP helps if it is given as early as birth. In any birth of preterm low birth weight baby, less than 34 weeks, less than 1,500 grams, if you give CPAP at the delivery room in a spontaneously breathing baby but having some labored breathing or respiratory distress, it has it has shown that it has reduced the NICU stay, reduced the need of mechanical ventilation, and also reduce the need of surfactant, and also reduce the risk of late onset neonatal sepsis or EONS, and also VAP. Because of this, CPAP is right now recommended. If after giving CPAP you are waiting for 2 to 4 hours, 6 hours, after that also respiratory is not improving and it is increasing, and the child is becoming cynos, the child's general status is deteriorating, or he or she is going on shock, then you have to give an exogenous surfactant administration, which is either natural or synthetic. Then, then you assess if improving, then with CPAP, wait and watch. Or else you go for mechanical ventilation if the child is not improving even after giving exogenous surfactant ventilation. So, CPAP. So, CPAP is nothing but, so I've just read it out, right? Uh, wait. Okay. So CPAP is nothing but it's a respiratory support to preterm neonates with respiratory distress who is spontaneously breathing. So what are the indication you give? So what you should know in the CPAP, you have a gaseous source which will give both oxygen air, and it should be blended in a mixture, and this will give a proper uh, recommended ratio of oxygen to the baby to avoid hyperoxia. You should always avoid hyperoxia. Both hypoxia and hyperoxia is detrimental to the newborns. So you cannot give over enthusiastically. You cannot give more oxygen. Assess him also over cautiously. You cannot also provide less oxygen. So it has to be blended according to the condition and the age of the baby, with the help of blender, right? And then you have to humidify to the temperature of the body, so that you don't do not provide a dry air which may cause damage to the nasociliary apparatus. And then that's the inspiratory link. This is the patient interface with which the you will be providing the CPAP or PWAP. And this is the CPAP pressure generator, which will provide an adequate PEEP according to the requirement of the baby. So you always initiate PEEP with the 5. You can go up to 8 centimeter of water. And the FaO2, that is fraction of inspired oxygen, can be start from 21% till 80%. Even after giving PEEP of 8 and FaO2 of 80%, if the respiratory distress is not settling, then this is known as CPAP failure. Then, so what are the indication of CPAP? The CPAP indication is preterm for RDS, TTN, pneumonia, apnea of prematurity despite metal giant therapy, or weaned from your elective, but the child was on intubation, then we are weaning it from, and if the child is suffering from tracheomalacia and bronchomalacia, then also we give the CPAP. So what are the contraindications? This is very important. Whenever the child has severe cardiovascular instability, poor respiratory diet, impending respiratory failure in the form of PA2 less than 50 and PCO2 more than 60, PaO2 less than 650 and PaCO2 less than 50. Then the child is suffering from impending respiratory failure, and if the child is having serious and death, you cannot give, you cannot, that is contraindication. So for mass, so any term postterm baby with IUGR will suffer from hypoxia. Sorry. Okay. Any term or post-term baby with IUGR who suffer from in utero hypoxia will have some kind of autonomic systemic activation leading to MSFE, that is meconium state amniotic fluid. Now, this meconium state amniotic fluid, the babies will aspirate and then it will develop the mass. So, most general complication of MS is your pulmonary hypertension. So, what are the pathology? The child will aspirate the meconium, and now this meconium, if it obstruct the large airway, will cause obstructive emphysema. If it obstruct the small airway, it will cause atelectasis, that is surfactant inactivation, and this meconium itself some kind of a chemical for which there will be an inflammatory response in the lung parenchyma, which leads to a chemical pneumonitis. These are the three pathology which is associated with mass. So this is the thing which I was telling. That is mechanical obstruction or the air trapping, lead to uneven ventilation and air leaks, which go for hypoxia acidosis, and that leads to primary pulmonary hypertension. And second thing, it can also cause affective infection and chemical inflammation leading to atelectasis and intrapulmonary shunting, because there is atelectasis, the blood will flow, but it will not receive oxygen, but the blood is flowing. So it kind of shunt, intrapulmonary shunting. And uneven ventilation and intrapulmonary shunting will go for hypoxia acidosis, and the child will develop the primary pulmonary hypertension. So management, supportive management, treatment of PPHN by giving inhaled nitrogen oxygen, and sometimes surfactant is also used. If after that also the child is not able, we go for HEC. And those baby who survive this mass period, then they have, this has been found in some studies that they may go for, they have an high risk for developing asthma in near future. So what is apnea? This is more common in preterm, that is known as apnea of prematurity. The most reason is due to the immaturity of central receptors and peripheral receptor, and also the brain. It's most commonly seen in the age of 2 to 5 days of life. And if the age is less than 28 weeks, the most of the time it is 80% the child will develop apnea of prematurity. And most commonly it is seen in 28 to 32. Apnea is nothing but it is a denote cessation of breathing for 20 seconds or less. And if it is associated, say, if it is only cessation of breathing, at least 20 seconds must be present. If no, it is less than 20 seconds, but there is cyanosis. That is cyanosis, and saturation. When you see saturation, is less than 80 or 85, 80 to 85%. And bradycardia, severe bradycardia, less than 80 beats per minute. If this both are associated, then even less than 20 seconds also we can consider apnea. So what are the causes of apnea? Central apnea, because of central driving force is absent. Obstructive apnea, because the pharyngeal airway of the muscles are not, the tone of the pharyngeal muscles are less, hypotonia. Then the child will have the pharyngeal airway hypotonia, and which collapses during breathing. As a result, the child will go for apnea. And the combination of both will cause them is apnea, which is most common. 40 to 60% of baby who is suffering from apnea is because of apnea. So always treat the underlying cause in case of secondary apnea. Any apnea that appears first within 24 hours of life and after 7 days of life, then it is not never be an apnea of prematurity. Then you have to rule out the secondary apnea. The most common cause of secondary apnea will be your infection. Metabolic is your hypoglycemia, hypocalcemia. CVS, any congenital cyanotic heart disease in CCF. In respiratory cause, RDS, pneumonia, TTN. And in CNS cause, any intracranial bleed, intraventricular hemorrhage, cerebral edema. In a hematological cause, it could be because of anemia of prematurity, polycythemia. Even also sometimes the apnea is seen in osteopenia of prematurity or metabolic bowel disease. Right? And some kind of inborn error of metabolism can also cause a secondary apnea. So for apnea of prematurity, you always start with caffeine and theophylline, which are nothing but your antagonist, adenosine antagonist. And then also respiratory support. Sometimes some babies require CPAP and some babies also require mechanical ventilation. Mind you, in apnea of prematurity, the child require respiratory support not because of the pulmonary pathology. If it's a primary as apnea of prematurity, it's not because of pulmonary pathology, it's because of a central driving force or the pharyngeal muscle hypotonia. So, in order to splint that hypotonia, to open up the splint that is caused by your hypotonia, and also it will also help in your driving force, the CPAP, will help. So with a minimum setting, we give CPAP as the mechanical ventilation. Cyanosis in newborn, we will discuss in the last. Before that, so cyanosis in newborn, it's because of respiratory cause and pulmonary cause. I will discuss in a short after the everything I complete because there is not much touch unless it will be a 10-mark question. We can further discuss in our previous chapter. So another most important topic, which for which I was teaching you NRP neonatal resuscitation program in so much detail for at least for 1 hour in the last class, is because to avoid this perinatal asphyxia or birth asphyxia. So what is this perinatal asphyxia or birth asphyxia? It is nothing but the injury to the fetus or neonate that occurs because of lack of oxygen or a lack of perfusion to paresol. The etiology could be antenatal, natal, and postnatal. So, what are the antenatal cause? Always is uteroplacental insufficiency, which is your PIH, uncontrolled GDM, or any placental insufficiency. In natal cause, it is your cord prolapse, abruption placenta, maternal hypertension due to acute blood loss, hypotension, and spinal anesthesia. And the mother is suffering from maternal chorioamnitis. In postnatal, what could be the cause if the child either suffer from severe hypoxic respiratory failure, severe sepsis or respiratory failure, critical cyanotic congenital heart disease, one of the DD for your perinatal hypoxia. All the critical congenital cyanotic heart disease, mainly your TAPVC, obstructive TAPVC, TGA with intact IVS, what is intraventricular septum, and your uh, okay, and then your pulmonary atresia with intact IVS. These are the conditions where which will present at birth. Most commonly, which is the critical heart disease will present at birth. Cyanosis at birth, you have to remember two things: TGA with IVS and hypoplastic left heart syndrome. Hypoplastic left heart syndrome and TGA with intact interventricular septum are the two major conditions which will present at a sudden onset of congestive cardiac failure and neonatal cyanosis at birth. So they will be asking. So these are the natal, intranatal, postnatal, and antenatal causes. So what are the that and always it associated with tissue lactic acidosis and hypercarbia. So what are the guidelines or the essential criteria to tell the child is suffering from HIV? HI, not HIV, sorry. HI one is umbilical arterial sample pH less than 7.2 with base deficit 12 millimole per liter and lactate less than more than 10. And if you are taking umbilical arterial sample as soon as birth, or if you fail to take the umbilical arterial sample, you also can take umbilical venous sample at birth, that is cord sample. If you fail to take the cord sample either from umbilical artery and umbilical vein, if you want to take the peripheral vein of the baby, it should be taken within 1 hour of life, not more than 1 hour. If you are taking more than 1 hour, that is no significant, that will not help in our the diagnosis. So it should be taken at least at the birth or within 1 hour of life. And if the Apgar score is at 5 and 10 minutes is less than 5, this is important because in your OPGI 9th edition, this given 0 to 3 at 5 minutes. 0 to 3 Apgar score at 5 minutes. Recent change is Apgar score less than 5 at 5 and 10 minutes. Then multi-organ failure, your cardiovascular, your hematological, your coagulation, your respiratory system, even your CNS, apart from the your kidney, renal, it will go for AK, there will be congestive cardiac failure, there will be a ischemic pneumonitis, there will be a coagulation, the coagulopathy, DIC. These are all the multi-organ failure, even gastrointestinal bleeding, that is GIT failure. So these are the causes of multi-organ disorder dysfunction. And last is important in your OPGI 9th edition or your classes also, they would have been said that it is your brain, abnormal brain uh, examination, like you have an increase in the tone, abnormal, altered sensorium, or convulsion, or seizure. But in 2019, ACOG, American Council of American College of Obstetrics and Gynecology, they are told that just neurological dysfunction is not important. You also should do see the imaging. So in recent guidelines, it has been seen that neuroimaging MRI brain in first 24 hours showing abnormalities like in your basal ganglia, in your thalamus, and your PLIC. These are the three areas which you have to see. Basal ganglia, thalamus, and posterior limb of internal capsule. So any lesion which are noted within the first 24 hours of life, mostly we go for diffuse weighted imaging rather than the T1, T2 conventional sequencing because the early change of the hypoxic ischemic encephalopathy in both term and preterm babies will be seen in this area only in a diffuse weighted imaging rather than T8, T1. T1, T2 will take at least 4 to 5 days to show the changes. But the diffuse weighted imaging, that is DWI, will catch your early changes, that is within first 24 hours. If that is positive, all these four criteria must be satisfied in order to tell the child is suffering from the hypoxic ischemic encephalopathy. Yes. So, what is the neuropathophysiology? And based upon our National Neonatology Forum database, we divide birth asphyxia into mild, moderate, severe. Mild is 0 to 3, Apgar based on the Apgar score, moderate to 4 to 6, severe is 7 to 9. So, initially, in case of term baby, it was said there is your parasagittal cerebral watershed injury is the most common cause of HIE in the term neonate. But as per the recent articles published in various international and national journals and in the OPGI 10th edition, they are now saying it is not your parasagittal watershed area injury. It actually your selective neuronal necrosis that involves your cerebral cortex and deeper nuclei leading to a dystonic cerebral palsy is the most common cause of HIE in the term neonate. So you will be asked this question because it's a recent change. Please note it down. Which is the most common cause of HI in term unit? Not your parasagittal cerebral injury. It's your selective neural necrosis involving your cerebral cortex and deep nucleus. But for the preterm unit, it remains the same. It is your PVM. That is periventricular decompensation. It's the most common mode of injury in a preterm unit and always lead to spastic diplegia. Right? IQ, intellectual deficit, cognition is impaired in the term neonate, whereas in preterm neonate, since your maximum cerebral cortex is not that much involved, in most of the preterm neonates, the cognition is relatively present. What are the staging? We use Levin staging and Sarnat staging. In Sarnat staging, we define it's a stage one, stage two staging. What is the reason why we have to differentiate it into stage one, stage two staging? See, it is the only thing we have to know the prognosis of the baby. If the baby is in stage one, most of the time the baby will improve and the child MRI will be near normal, USG will be near normal. The child will have less like they have less likely have to have seizure. If everything is normal and MRI is normal, uh, PH is also normal, then you go for stage one and they have a normal neurodevelopmental outcome. If the child falls in the stage two, then their 20% of their child will have the adverse neurological outcome, that is the dreadful cerebral palsy. Whereas the stage 3 is very determinantal, 50% will die, whereas the 50% will have a adverse outcome. So, for prognosticating the future of the baby, whether the child will have a normal neurodevelopmental outcome, neurosensory outcome, or the child may die, or the child may go for severe neurodevelopmental outcome like cerebral palsy, it can be done by a Sarnat classification, that is Sarnat clinical staging. Which another staging, it's given in my OP card, so just go through it. What is 11 stage? So what is the post once you resuscitated the child, now the child heart rate is improved and everything is fine. So you go with this table. So you have to at 5 minutes the Apgar score was 5 and you are 7. And the chest compression and adrenaline you have to give and PP was given for 15 minutes. So you have to transfer the child to NICU and monitor the baby. If the child is hemodynamic stable and normal tone, the activity is normal, sensorium and no seizure. After 48 hours, most of the time, if the seizure doesn't happen within 48 hours and everything is normal, child, and you have started with trial feed and the child is taking the feed, then better shift the child to mother's child and initiate breastfeeding. But during the NICU stay, if the child develop abnormal tone, activity, and the child also had a presence of seizure, then you have to maintain a normal temperature, prevent hypothermia, maintain normal oxygenation and ventilation. I would say never hyperoxia and hypoxia should be avoided. You have to maintain a normal PaO2 of 80 to 100 and PaCO2 of 35 to 50, sometimes 60 is also, that is, you go for uh, PaCO2 of 60. So you are so this should be normal oxygenation and ventilation by judicious use of oxygen by maintaining PaO2 of 80 to 100 and PaCO2 of 35 to 50, sometimes 60, and ensure normal perfusion by giving saline molasses if there is a shock, or else you can go for vasopressin as required. Always maintain hyperglycemia and hypoglycemia should be avoided. Normal blood sugar by infusion of IV dextrose. Treat for seizure and monitor the baby. So normally the seizure in HIE is intractable for the, as I said, if the HIE causes the seizure, it should occur within 48 hours. If it occurs within 48 hours, it will be intractable. Even giving all sorts of your AED, the seizure tends to continue. But sometimes it has been found in most of the cases after 48, it automatically burns out, and and then you have to see how much days the seizure is absent. If the seizure is absent for 3 to 4 days, you have to stop all the AD you started except for phenobarbital. At the time of discharge, you do a neurological examination. If the neurological examination is normal, stop phenobarbital. Right? No, that's you see the neurological, the tone is increased. The side is somewhat lethargic. The tone is increased, hypertonic. Let's see. So then it is an abnormal neurological examination. Then you have to continue the phenobarbital for another 1 month. Then again ask the mother and father to take the child again after 1 month. If after reassessing it's after 1 month you are saying it's normal, then stop phenobarbital. No, even after that, the tone is still increased. Then you have to continue phenobarbital for 3 months. After 3 months of phenobarbital, again the child has to come to the hospital. You do a neurological examination. If the normal, stop phenobarbital. But still the tone is increased. Now you are seeing that still the tone is increased. What to do? Then at this stage you have to do an EEG. If the EEG tends to be normal, now you stop phenobarbital. But after abnormal neurological examination, thrice you checked, and then the 3 months you see the neurological examination again normal. You do an EEG. It again the EEG for background is abnormal. It's not up. It's very abnormal. Dysarrhythmic is present. Dysrhythmia is present. Then slow wave pattern is present. Then you're saying that means the child is still having the seizure. Then better go continue the phenobarbital, or you have to have some other drug in order to. And if this kind of baby will have a poor neurological outcome. So neonatal seizures. So this per time say this is another 10-mark question. The most common and distinctive clinical manifestation of neurological dysfunction in the newborn infant. What is the definition? It's a defined clinically as a paroxysmal alteration in the neurological function. It could be motor, it could be just behavior or autonomic function. Either motor हो सकता है, it could be behavior or autonomic. So we have two type of seizure, which is non-epileptic seizure or epileptic seizure. Epileptic seizure also, we have some motor dysfunction. You are seeing some motor overactivity associated with their corresponding EEG seizure activity. If EEG seizure activity is present, then it is known as epileptic seizure. Whereas if the clinical seizure just you have motor, the child is the hand is jerking, or you have a cloning type of seizure, but there is no corresponding without EEG correlate, then you have subtle and centralized tonics. See, subtle seizure is the most common seizure. See, I will be, this is a subtle motor seizure, right? This is the most common seen seizure manifestation seen in infant, and most common cause is HIV. So, what you will see, the child will have a Staring loop with cycling, pedaling, or rowing, kind of rowing, boat rowing with lips battery. Any one of this will be continuously present. That is a subtle motor seizure. This is seen most commonly seen in HI. Or else there will be noting there will be a persistent tachycardia with apnea with tachycardia of more than 180 beats per minute, which is persisting for at least more than 5 to 10 minutes, despite treating for all other causes, it could be tachycardia. Then you have to suspect seizure and you have to treat accordingly. Okay. Other like focal tonic, myoclonic, epileptic spasm. Generally, they are rare form, but they are also manifesting. Most commonly, you see a subtle motor seizure in the newborn, and most commonly because of HIE. So, what are the cause? Most common cause is HIE. Second most common is ischemic stroke. Third most common is intracranial hemorrhage. Sometimes infection can also cause. What is the management? Always, when I use whether it's a true season, ensure TBC. You have to secure IV line and check for blood and glucose. Always check for blood glucose. Blood glucose and calcium should be checked before starting AED because most of the time, if hypoglycemia is present less than 40 mg per deciliter, that would be the cause of the seizure. If you treat that cause and seizure settles down, then probably it is a hypoglycemia that cause seizure and there is no need of AED in that case. If the child has glucose more than 40, still the child is convulsing. Then you go for IV phenobarbital of loading dose of 20 milligram over a period of 20 minutes. Till the seizure continues, then you give a repeat IV dose of 20 mg in 2 aliquot, 10 mg per kg into aliquot. The cumulative dose you can give 40 mg per kg. The total is 20, then you give 10, 10, 10. Right? 5 minutes interval, 5 minutes interval, you see. So after that, you give 40. After the 40, you cannot give again phenoma because giving excessive phenobarbital above 40 are found to be detrimental to the child. Till 40, you can see whether the child improves or the child seizure settles. If the child seizure settles, then go with the maintenance dose of 3 to 5 mg per kg day of phenobarbital in two doses, 2D. Even after that, if the seizure continues, you have two options. Either you go for phenobarbital at recommended doses. If it settles, then go for maintenance dose as given in the slide. Or else, sometimes in few hospital setting, we even go with either of starting phenobarbital, we go with levetiracetam as second line with dose of 50 mg per kg over 20 minutes. If the baby seizure settles, then with a maintenance dose of 40 mg per kg per day in two divided doses. Even after either you try phenytoin or levetiracetam, you are given the maximum dose. Even after that, the seizure persists. Then you have to administer IV metrazolone at a rate of, at a rate of 0.15 mg per kg. This is the loading dose, which has to be followed by the continuous infusion. 1 microgram per kg per. And we have to, once midazolam has been given, anyone can tell what is the side effect of midazolam? Yes, it is respiratory depression. If you have given midazolam, try to increase the respiratory support, go either CPAP, but if you require a more increasing the infusion rate, then better go with the mechanical ventilation. Even after that, the seizure persists, go with IV lidocaine, and that is sometimes there is a refractory seizure not amenable with all the drugs which I have given. Then that refractory seizure not amenable to any AED as shown in the chart, then you have to suspect some kind of IEM. For that, most common IEM which is causing this kind of things, pyridoxine responsive epilepsy or seizure. So here, this pyridoxine responsive epilepsy or seizure, we give with the trial of IM pyridox of 100 mg for 4-5 days, and we will see what is the. So this is the management. Another important in the flow chart, in initial stage itself, I told you have to separate jitteriness, the seizure, true seizure. You have to define true seizure, whether it's a true seizure. If any seizure with electro EEG correlates or there is no clinical manifestation, but you when you do an EEG, you are finding some EEG correlate of seizure, then you have to treat that seizure. But any clinical seizure with some kind of rolling of right, your pedaling, lip smacking, but on doing EEG, you are finding there is no seizure activity, then that is clinical only seizure. In many scenarios, it has been found this clinical only seizure is most normally a seizure mimic. So, one of the most common seizure mimics is jitteriness. How to differentiate jitteriness versus seizure? Normally, jitteriness are fine nature, whereas seizure are coarser nature. Jitteriness are provoked and by stimulation, and they are stopped by grasping the hand of the child. But the seizure are not stimulus sensitive and they continue to move even if they are grasped by the hand. Eye movements are normal in jitteriness, whereas eye movements are abnormal in seizure. Autonomic changes will be absent in jitter, whereas your tachycardia, apnea will be seen in your seizure. In jitteriness, neurological examination normal, EEG will be normal, whereas neurological examination may abnormal and EEG will be abnormal. So this is way you have to differentiate. This is the most common question they have been asked in your university and in Viva in neonatal station. You are bound to answer this answer because it's the most common question asked by every external as well as your internal examiner. So infection of neonate. What are the superficial infection like operculitis, oral thrush, conjunctivitis, pustules? This infection are not say the neonatal sepsis, mind you, right? If the question asked to explain about neonatal sepsis, never, uh, sorry. In the question, if they ask neonatal sepsis, never ever write about the omphalitis, that is your umbilical infection, oral thrush, conjunctiva, pustules. They are superficial infection. With the exception, if the superficial infection like the operculitis, that is the induration or redness around the umbilicus, goes more than 1 centimeter with the systemic features of infection, then you have to rule out sepsis. And if the pustules, if it is more than 10, then you have to suspect sepsis. Apart from this, these four conditions, never ever write this in your exam, in your theory paper, or tell in your exam they are the neonatal sepsis. So neonatal sepsis is defined when the organism gains an entry to bloodstream, leading to bacteremia with systemic inflammation that is response to the infection will lead to septicemia and sepsis. So what are the two types of sepsis? What is EONS, early onset neonatal sepsis, which occurs less than 72 hours. If it occurs more than 72 hours, it is late onset neonatal sepsis. We'll see this thing. Any neonatal sepsis that occurs within 72 hours, it is early onset. More than 72 hours, late onset. Most commonly, the perinatal risk factors are always in the maternal genitalia or the labor room environment. So one of the risk factors is prolonged rupture of membrane more than 18 hours. Right? Here in late onset sepsis, it is a NICU and other risk factors like low birth weight, poor hand hygiene, aspiration of fluid, use of an intravenous fluid, and puncturing the child more than 3 or 4 times you're puncturing for making IV line or take the sample. It is most the organism mostly is your NICU aerogram, aerobiogram. Whereas early onset, it is your many maternal genitalia tract organism or most common cause of the early onset, late onset neonatal. In developing countries like our country, like India, it has been said that the both a common causative organism for the early onset as well as the late onset neonatal sepsis are similar. They are your Klebsiella pneumonia, Acinetobacter, and Staphylococcus aureus. In some cases, it could be cognizant active cons Enterobacter pseudomonas. Normally, early onset neonatal sepsis present as pneumonia. This is most common, whereas in late onset it has a generalized sepsis, pneumonia, or meningitis. Case fatality ratio, that is ratio, is more high in your early onset, whereas it is late onset. If the child, along with the depression with shock, bleeding, scleroderma, renal failure, then the child will said to be having in a septic shock, and that has to be treated in an urgent basis, or else it will increase the mortality. So, what are the symptoms you will see? Clinical feature, it is always non-specific, but see to this, a child, a neonate was feeding well, either a spoon feed, palade feed, or breastfeeding. Suddenly, you see there is an alteration in the established feeding behavior. That is, initially he was feeding very well with spoon feeding. He was taking about 20-25 ml assault in an assault way. But right now, even feeding a 10 ml become a very problematic for him. Or else now he's not even breastfeeding properly, which he initially did very well. Now his sucking reflex gone. Sucking is very poor. So there is an alteration in the established feeding behavior. This is the earliest sign that is symptom seen in the case of neonatal sepsis. What system wise you will see? Chest retraction, work of breathing, tachypnea, respiratory system. Hypertension, cold periphery, tachycardia, seizure, altered sensorium, white tense antirefill if the child is associated with the CNS complication like meningitis. Like so, what is the treatment? It's simple. This is simple. Any investigation thing. Any neonate with suspected sepsis, you are suspecting neonatal sepsis. It could be early onset or late onset. As I say, early onset neonatal sepsis, a triple I, that is your choriamnitis. If the PPROM is more than 72 hours, then you do a scoring called as early onset neonatal score, which is done based on your PGI Chandigarh score, where we see the score is more than 7. Then you have to take blood culture. That is the standard guideline in books they say that you have to say sepsis screen, then if that become positive then I will go what's blood culture. No, before starting the first dose of antibiotic, whenever you prick the child for taking blood or for securing an IV line or gelco, take about 1 ml of sterile blood for blood culture. It should be taken at first instance only, not your sepsis screen. Sepsis screen can wait. Whereas blood culture is the standard investigation which have to be done for any suspected NNS, whether it is a early onset or late onset. Always do a blood culture along with sepsis skill before starting antibiotic. So if the score is more than 7, yes, then blood culture and sepsis skill. And also you start empirical antibiotics. If blood culture and subsystem become turns out to be negative, stop antibiotic and find out any alternative diagnosis. But both came as positive, then do an LP and treat the LP means lumbar puncture and treat accordingly. But if it came as a late onset neonatal sepsis, more than 72 hours, you have seen the sign and symptom, risk factors are present. You are at instant before starting empirical antibiotic or start giving a first dose of antibiotic, you have to give you have to take blood culture. LP should be done irrespective of whatever be the result you will get, because meningitis is most commonly seen in LONS, whereas EONS is less common. As a result, blood culture LP sepsis skin should be done before starting any empirical antibiotic. It has to be done, then start empirical antibiotic. If result become positive or negative, then accordingly you manage. This is the chart which I explained. So what's the management? Supportive management, TABC, warm, and oxygen. Perfusion, C for CRT. If CRT is more than 3 seconds and urine output is decreasing and other clinical parameters are worsening, then the child is going into shock. You give an NS bolus of 10 to 15 ml per kg over 10 to 20 minutes 2 times. If over the even after that the child is not able to start vasopressors, inotropes, secure an IV, peripheral IV line, give IV dextrostem. Most of the time, the neonatal sepsis babies are more prone for hypoglycemia. So when you cannot check for a glucose, or in your center, you're lacking that monitoring devices like your glucometer, then give an IV 10% dextrose instantly, and then you have to give nutrition, whatever be the antibiotic, whatever IV should you give without optimizing the nutrition, the child will not require, because sepsis is a catabolic process. Your protein energy is utilize that. So the child required protein and energy for his regenerating growth. The child must have a positive nitrogen balance. As a result, go for optimum nutrition like TPN, that is total parental nutrition. Enteral nutrition can be started when as soon the child hemodynamic stable status. Specific antibiotic therapy, we give an empirical antibiotic. The first line should be covered 60 to 70% of the the organism that is very prevalent in that NICU or in that particular hospital. Second line should cover at least 90 to 95%, whereas the third line is very specific. We give a very specific is here 99% of the organism should be covered. So normally in our setting, in our hospital, we always start with the pipsomic acid. And then once the blood culture reports are available, we go with specific therapy. The antibiotic stewardship program is nothing but you have to give right antibiotic at the right time and dose for the right duration to the right. So how to prevent sepsis? Six cleans, which I told in the previous lecture. Exclusive breastfeeding, as I say, it reduces 14 times diarrhea, 4 times pneumonia in neonates. So exclusive breastfeeding is a immunological advantage is that. So you always given that exclusive breastfeeding. Always do an hand hygiene before and after touching baby of at least 20 seconds. Before entering NICU or SNCU, at least for 2 minutes, you have to you wash your hand. And before and after touching, you have to do a 20 seconds of hand rub or hand hygiene. Avoid unnecessary invasive intervention like IV fluid, IV cannula, and unnecessary medicine. And KMC, already discussed, for stable but liver, this will prevent sepsis. Last topic, which I will be discussing. And since it's we are just 10 minutes before 8. Today I'm not going to start nephrology. Next week, most probably we will deal with the nephrology. Sorry for the delay, but being a neonatology is a vast subject. I cannot shorten it just because you will not read it any other subject like medicine, surgery, ops gynae. This is not the topic which is given in any other subject. In pediatric only, we will be reading this neonatology. So that's the reason why I give the more weightage to the neonatology. So I started first. So with this, I will be completing the neonatology. In next class, that is your next Friday, we will be talking about the nephrology. Okay. So neonatal jaundice, which is the most common case, short case given in your viva, in your practical. So you should know in and out of the neonatal jaundice, how to look for neonatal jaundice. The examiner will ask you to examine the baby, look for neonatal jaundice. So, what are the approach you will do? How to look for the dermal icterus? What are the do's and don'ts while doing that? It should be very in and out. You should know because it's a very basic. It's very simple way you can examine it. So we will be seeing this. So any yellowish discoloration of skin and sclera of the newborn, it's known as neonatal jaundice. 60% of term and 80% of preterm become visible jaundice in the first week of life. Whereas 5 to 10% of this neonate only had a significant jaundice and they require phototherapy and exchange transfusion. So this question, this pathological jaundice, have been asked as a 10-mark question in a recent TNMGR MU pediatric paper. So be thorough with this topic. As you know, your question paper from this year, it's 100 mark. So your question paper will shortly will have the jaundice question. So don't go without reading neonatal jaundice. This is one of the simplest topic, most important topic, which is a common scenario. You will be noted in all neonates. So without reading this topic and you're going to exam means you have to suffer the consequences. That's it. Okay, but okay, we'll go with the topic proper. What is physiology versus pathology? Any jaundice that appears after 24 weeks, 24 hours. For term baby, it's less than 2 weeks, and preterm it is less than 3 weeks. And term baby, it's less than 2 weeks, but preterm for sometimes 10 days. Term baby were on formula feed. So they are found that in formula feed baby, the jaundice disappear as early compared to a term baby who's on breastfeed. Serum bilirubin raising is less than 0.2 mg per deciliter per hour or less than 5 mg per deciliter per day. If TSB range at any time is less than 15, involvement of palm and soul is no. Sign of acute bilirubin encephalopathy is no. Direct bilirubin is less than 2. See, this is less than 1. Please note it down. This is wrong, less than 1. But what is pathology? Whenever it happens less than R24. What is the pathological cause of jaundice? More commonly, please tell is RH incompatibility. RH incompatibility should be coming in your Viva. Whenever asked what is the most common cause of pathological jaundice, if you suspect, is it RH incompatibility, ABO incompatibility, maybe the child may have a GCSPD if it's a male child. Okay, and may sometime it could be also your hereditary spherositis, maybe cause of less than 20 hours. If the term may be persisting of jaundice more than 2 weeks, preterm more than 3 weeks, if the race is more than 0.2 mg per deciliter per hour, and if it's more than 0.5 mg per deciliter per day, if at any instance the TSP is more than 15, palmar soul involvement is present, acute bilirubin encephalopathy is present, then go direct bilirubin more than one, then it's a pathological jaundice. So this is how the way you will have this jaundice. It's a simple way. So what is the difference between the breastfeeding and mixed milk jaundice? This is also an important question. Breastfeeding jaundice is because you don't give an adequate milk. So here, because of you are not giving adequate milk, the child go for dehydration. Because of dehydration, there is increase in the enterohepatic circulation. So all the bilirubin that has been washed out into the gut will be reuptake and it will again go into the circulation and cause the jaundice. So here you should give fluid and calorie supplementation and give a breastfeeding. This is more than enough. Whereas the breast milk jaundice, it appears at day 4, it reaches up at 14, 20 to 30 ml and decreases normal by 4 to 12 weeks. So it appears late. It appears third day with 4, but it peaks by 14 days, 20 to 30. But by 12, but 3 months of age, the child's breast milk jaundice decreases. Unknown because there is beta glucuronidase like substance in breast milk, which increases the intrahepatic concentration. If in order to rule out whether this is because of breast milk, some doctors and some scientists said that if you stop, Otter says that if you stop breast milk for next 48 hours, then you will dramatically say that it will decrease less than 10 or 7. Then you can diagnose. But as per the IAP, as per your NNF guidelines, in order for diagnosis or to treat, stopping breast milk is not indicated. You don't need to stop breastfeeding in a suspected case of breast milk jaundice. Instead, you can start phototherapy. Most of the time, it will settle. So there is no indication to stop breastfeeding. So what are the way you see? Okay, let's see. Kramer's rule. You sit for a. I will discuss in this. The normal ictus every 12 hours after 24 hours of the light should be done in a natural light with the digital pressure. Digital pressure with the thumb, you just run over the skin. Once you remove the pressure, you will see the blanching. You will see a yellowish blanching, and you should see in a natural light or white light, not in a yellow light because it will give a false positive for the jaundice. So this is the thing which the examiner will look for when you examine the baby. Always say that I want to watch, I want to see for the dermal icterus in the warm sunlight or in the white light, because in a artificial light or in any yellow light it will give a false positive result. If you say that even we don't examine, the examiner will say okay. So you know that he or she will know that you know the concept very well. So visual inspection after 24 hours of light, every 12 hours, do this camera rule, dermal icterus, natural light, digital pressure. Transcutaneous bilirubin level. Here, you will use an instrument called as transcutaneous bilirubinometer, which will see the TCB level, which will measure the yellowishness of the subcutaneous tissue. It is fair enough till 13 mg. Whenever it tell 12 to 13, okay. Then the values more or less it's 12 to 13 only. But whenever it shows more than 13, it less likely it relates to the actual serum bilirubin. At that instance, before starting phototherapy, you have to send a blood sample to rule out actual TSP. So serum bilirubin level should be seen for pathological jaundice, for decision making, and when TCB associated more than 30, both direct and indirect bilirubin should be. Okay, sorry. So, so this is the Kramer's rule you are seeing. So just muggy cram it up. Face, chest, upper abdomen, lower abdomen, thigh, arms, lower legs, arms, soles. So these are the things, and this is the value with which you will see. This is more non-specific. It's more subjective. One time I can see, I will say it is 10. For you, it will maybe looking like it's up to chest or upper abdomen. For me, it's up, I will say it's lower abdomen. So it is very subjective. So we more likely, if you want to treatment or any pathological jaundice, then go for either TCB or TSB. This is the TCB. This is transcutaneous bleeding, right? Okay. Uh, so what are the causes? As I said already, pathological and physiological. Okay. So this causes of pathological jaundice. But only I will say the pathological jaundice. What would be? It's because of increased bilirubin production or decreased bilirubin clearance or increased enteropathic suppression. If increased bilirubin production could be because of hemolysis or non-hemolysis. If it's because of non-hemolysis, it could be cephalometoma or polycythemia. If it's because of hemolytic, it could be extrinsic, maybe mediator, AVRH, or sepsis. If intrinsic, SHH would be membrane, spherocytosis, elephytocytosis, or enzyme like GCSPD pyruvate deficiency. It is because of bilirubin production increase. If the bilirubin clearance is problem, it's your Gilbert, Krigler-Najar, and breast milk jaundice. If there is an increase in enteropathic circulation, that is a dehydration, GA obstruction, and breastfeeding. And any direct of always rule out neonatal cholestasis, which is a separate topic. So these are the risk factor. Go with the table which is given in the please note 10th edition. I have the changes. What are the changes you see? The Down syndrome, macrosomic infant of the male baby has been removed from the risk factor. The male baby is not a risk factor for a developing significant hyperbilirubinemia. Whereas the new factor is Down syndrome and macrosomic infect of diabetic mother. I guess they are the two things which have been added in the recent AAP 2022 guidelines. Initial last guideline was released in the 2004, right? After that, now after 12 years, they have been releasing this recent guideline. And in neurotoxicity risk factor, any gestation age less than 38 weeks, albumin less than 3, isoimmune hemolytic anemia, disease, if sepsis, or clinical instability in the previous 24 hours. If any one of this present, right? If then you say the child have a neurotoxicity risk factor approach. So this is the NNJ chart which is given for phototherapy result with or without neurotoxicity risk factor, exchange transmission threshold with or without. This you go to your book which is given in your OP guide 10th edition, not in your 9th edition. Or you can download from website also, or I will give in the Medusane group. Just go through it because it could be an OSCE chart, OSCE chart. Any prolonged jaundice that is beyond 3 weeks of life, that is persistence of significant jaundice of more than 10 mg per deciliter beyond 3 weeks of life in a term neonate, or if a child has dark urine or significant jaundice, always rule out cholestasis, that is for pediatricia, ongoing hemolysis like GCSPD, hereditary spherocytosis, or cephalometoma, congenital hypothyroidism, and more importantly, which is less likely seen in neonate and mostly which we don't give that much care is your UTI. UTI in neonates can cause prolonged jaundice. So these are the four etiology you have to rule out any prolonged jaundice beyond 3 weeks of life. So management supportive TAPG, we go for discrete specific thing. Phototherapy, double volume exchange transmission, IVG. So phototherapy, so this is a mainstay for treating unconjugated hyperbilirubinemia in neonate. So what we do insoluble bilirubin is converted to a soluble bilirubin, which is removed in your urine and feces. What do? You do a configurational isomerization where Z isomer is converted to E isomer, which is a 25% of your bilirubin is excreted by a phototherapy through this method, but it is very slow. Whereas the most common method, and which is high removal rate, is structural isomerization, where it converts to a lumirubin. So lumirubin, this is the product you should know. That goes rapid removal. The least method you need other mechanism is the photooxidation, which is least produced under photoproduct or excretion. By this way, we convert insoluble to a soluble bilirubin or insoluble to urine. That's the reason for removal urine, the child should be fed adequately, exclusive breastfeeding or IV fluid, whatever, so that she or he never develop a dehydration. If the dehydration develops, the urine output decreases, and you cannot remove even the soluble bilirubin. So adequate of hydration through proper breastfeeding should be maintained in all babies who are on phototherapy. Characteristic of phototherapy, we use LED lamp. Initially, we use CFU, which is now outdated. In many centers, we use LED lamp. The wavelength is should be 460 to 490, which is a blue-green light. This has a maximum absorption capacity for the bilirubin. The minimum irradiance of 30 microwatt to centimeter square per inch dissolving. Very important. Whatever I about this should be written as well as told in your Viva, because these are the important point any examiner will be asking you for. Maximal surface area must be exposed except for your genitalia and the eyes, which has to be covered properly. 30 to 45 centimeter between baby and phototherapy, or as per the manufacturer instruction what they are selling, please follow them, right? Ensure optimum breastfeeding or minimum interruption. So this is the phototherapy machine. See, so here your baby is been sleeping. So this is your phototherapy, which is giving a blue green light with 460 to 490 nanometer. The distance should be 30 to 45 centimeter. Cover the eye and genitalia. Minimum interruption except for feeding and changing the diaper. Maximum exposure of child just by covering eye and genitalia only, and the irradiation should be 30 to 30 microvolt per centimeter square per nanometer. So whenever you give a phototherapy, always monitor the temperature, because they are more prone for hypothermia every 22 to 4 hours. TSB should be monitored every 12 to 24 hours. You have to discontinue phototherapy once two value is below the PT range as per the your AAP 2022 phototherapy threshold with and without neuro risk factor chart, which is provided by AAP recent 2022 guideline. We have to trace it. If it falls below the PT range, then you can stop the thing. If it is a non-hemolytic cause, one value is enough. If it's a hemolytic cause, you have to at least do two values, 12 hours apart. And if it go in that two value, if it is below that range, then you can stop. Indication of DVET. Any DSP age-specific ET range, as I say, according to the chart given, and sign and symptom of AB like seizure, hypertonia, opisthotonus, increased incessant cry, high-pitched cry, all other signs of acute biliary insecurity present, or your ET range in your chart, it is going above ET range, then you go with ET. And if you are seeing RH isoimmunization, then cord blood sample should be taken. If the RH isoimmunized matter, then cord blood sample should be, if hemoglobin is less than 10 and bilirubin is more than 5, then go for ET without any weight. In some case, we go for the IVIG also. So follow up of NNJ, neonate of serum bilirubin about 20 mg per deciliter at any point must be followed up regularly, and who have underwent double volume exchange transfusion. These are the two cases must be followed up regularly at every immunization visit, and you have to rule out anemia because they are more prone for anemia, which you have to treat with along with transfusion if needed, and hearing assessment because ABE may cause hearing impairment. So for this, maybe we should do BERA. So, guys, I guess so. This is the end of the neonatology. So we have started the topic from the neonatal resuscitation program, which is very important for your theory, practical, viva, and in all your clinical scenarios, in your day-to-day scenarios in OPD, as well as the neonatal ICU. So in and out, you should know, read it twice and thrice before going to the exam, because in oral viva table, this is the question they will ask. Then we discussed about the routine care of the newborn. Then we talked about the breastfeeding. Then we also talked about the preterm and low birth weight care. We discussed about what are the risk factors and what are the problem that is associated with preterm and IUGR, small for gestational age, and then what are the feeding pattern, what are the growth pattern or growth monitoring, and what are the vitamin and mineral supplementation you have to do. And then we discussed about the neonatal respiratory disorders, and we gave some insight over that. And we also discussed importantly perinatal asphyxia, birth asphyxia, neonatal seizure, and also importantly neonatal sepsis. And lastly, I also discussed the energy, which is the most common important topic. The only two things which I didn't discuss in neonatal hypoglycemia, for which I guess you have a chart in the OP guide. Just go to the chart. That's more than enough. It's not a eloquent task. And then cyanosis of neonate, which we will discuss in the CVS case class, where we will discuss it properly. So I hope today class was very crisp. I completed 2 hours within 2 hours, just 5 minutes extra. Sorry for the voice break, because I have kind of LRTA, kind of sinusitis. As a result, just a voice break and intermittent cough was coming in between our class. Sorry for that disturbance. Hope you enjoy class. If any doubt is there, please do put in the group, in our WhatsApp or Telegram group. I am very happy to help you out in the discussion. So with this, we are ending the neonatology. So now I hand over the session to Raghunandan.
Thank you, sir. Thank you so much. It was really a eye-opening session, and almost I think yes, it is useful for final year as well as the interns and post-interns who are preparing for their entrance exam also. Thank you so much, sir, and I hope we will join together in the next session. And if you have any
Sure, sure.
doubts, guys, you can put it in the chat box or in the comments of YouTube, or you can put it in the WhatsApp group so that sir will